Millions of adults in the U.S. are diagnosed with vascular disease, and it's no wonder. With over 60,000 miles of intricate arteries and veins throughout the human body, there are bound to be complications due to blockages, weakening of the blood vessel wall, and other issues impacting the circulatory system. With an aging population and the growing incidence of risk factors such as diabetes, high blood pressure, obesity, smoking, and the disproportionate incidence of vascular disease in our minority populations, the management of vascular health is becoming a key focus among today's healthcare leaders and providers. As with any medical disease or condition, it takes an entire team of dedicated professionals to find new ways to efficiently diagnose and treat patients, as well as to improve their long-term care. In vascular health, the leader of the team is today's vascular surgeon. Only vascular surgeons dedicate their entire training and practice to address the full spectrum of vascular health, as well as provide comprehensive care that includes preventive, medical, surgical, and minimally invasive solutions. Through ongoing education and research, as well as pioneering new techniques, vascular surgeons are on the leading edge of clinical breakthroughs that are transforming vascular health. As part of their comprehensive approach, vascular surgeons partner with other healthcare professionals to provide quality care tailored to each patient. This patient-centered model is vital to help all physicians manage vascular health in at-risk populations and promote healthier lifestyles in the future. Vascular surgeons are involved in every part of the disease process, from making the diagnosis to the management of disease. Vascular surgeons are comprehensive leaders in vascular health. Today's vascular surgeons are creating a new chapter in the vascular health story with improved patient care, better outcomes, collaboration, and leadership. Surgery is only part of our story.
Welcome to our live webcast, Financial Impact to Vascular Surgery with the Change in EM Reimbursement. Thank you for joining us. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of your screen, you'll see the Q&A polling window with tabs for each function. Please note, if you don't see the Q&A polling window, make sure that your viewing screen is not on full screen mode. On the Q&A tab, there is a large window which will hold all of your sent messages and a smaller text box at the top where you will type in your questions for the panelists. To send a question, click in the text box and type your text. When finished, click the Ask button. All questions that you submit are only seen by today's presenters, and a few will be selected for panel response during the presentation. During this presentation, you will see several polling questions. When a poll is active, it will automatically appear in the Q&A polling window. To participate in the polls, please select the buttons to the left of the answer that represents your views or experiences. Finally, there's a chat feature available for the audience to share ideas during the presentation. On the top right of the viewing screen, simply click on the conversation bubble to start chatting. The panelists cannot see this chat conversation. If you have a question for the panelists, please make sure to type that into the Q&A window to the right of your screen as mentioned above. We are joined today by Dr. Kim Hodgson, immediate past president of the SVS. At this time, I would like to turn the microphone over to Dr. Hodgson for opening remarks and panelist introductions.
Thank you very much. I'm Kim Hodgson, immediate past president of the SVS, and I'm joined today with my co-moderator, Dr. Matthew Sideman, who's the chair of the SVS Advocacy Council and is associate professor in the Division of Vascular Surgery at UT Health System in San Antonio, Texas. Before I move on with the rest of the panelist introductions, it's kind of customary to recap some of the recent events that we had, the recent town halls. And of course, we haven't had any town halls for the last month or so because we've been doing more important things with SVS Online, where we witnessed the first ever virtual SVS business meeting, the first ever virtual SVS election of officers, and the first time that all qualified SVS members were allowed to vote. We owe our great debt of gratitude to SVS staff and volunteers who made SVS Online possible and the great success that it was. I can give them my wholehearted congratulations. They just did an outstanding job rescuing us from the COVID-19 challenges that we faced. Well, I want to just take a few minutes giving you a preview of up-and-coming SVS Town Halls. In about 3 weeks, on the 30th of July, we'll be talking about putting the new SVS branding and valuation toolkits to use. This will be co-moderated with Dr. Joe Mills. The next town hall 2 weeks later, Thursday, August 13th, will be on equity and diversity in vascular surgery. Where can we do better? This will be co-moderated by Dr. Vince Rowe. And then our last scheduled town hall for the summer, at least, is on Thursday, October 27th. And we're going to be talking about some really cool initiatives from the new SVS Health IT Task Force, co-moderated by Dr. Judith Lynn. So to get back to today's town hall then, with the rest of the introductions, we're joined today by Dr. Michael Dalsing, current Vice President of the Society for Vascular Surgery, just elected to that position a couple of weeks ago. Congratulations, Dr. Dalsing. He also has served as chair of the SVS Pac Committee and is the Director of Vascular Surgery at Indiana University School of Medicine. Dr. Sunita Srivastava is the chair of the SVS Coding Committee and Director of Quality in the Division of Vascular and Endovascular Surgery at Massachusetts General Hospital. Dr. Megan Tracy is chair of the SVS Government Relations Committee and Associate Professor of Vascular Surgery at the University of Virginia. And lastly, Dr. Robert Zolak is a past president of the Society for Vascular Surgery and currently Professor of Surgery at the Giesel School of Medicine, Dartmouth-Hitchcock Medical Center. And while Bob doesn't hold any current active roles in SVS leadership or governance, he is well known for all the work he's done on coding and reimbursement issues over the years for the Society. So with that as the formal introductions, at this point in time, I'll be turning it over to my co-moderator, Dr. Matt Sideman. I'm going to unshare my screen here, and we'll get going.
All right, thank you very much, Ken, for getting us started. And I'll take it from there. So we're going to go over a little bit about the structure and function of the Policy and Advocacy Council, and talk about each of the committees that make up the council. And then we're going to demonstrate how our committees work synchronously to advocate for the SVS membership. And we're going to take the upcoming issue of E&M coding changes to demonstrate how that works. So Dr. Zwolak will talk to us about how these E&M changes came about, as he was a member of the joint CPT-RUC work group that helped create them. Dr. Srivastava is going to tell us about the creation and valuation of the new E&M codes. Dr. Tracy will talk about the financial impact of the Medicare cuts and the role for SVS advocacy. Dr. Dalsing will talk about how the SVS PAC dollars will fuel the fight against the E&M impact. And then I'll wrap up with a couple of comments about all of the data that we've given you, and we should have plenty of time for questions and answers. So the SVS Policy and Advocacy Council evolved really out of over a long time from a group of dedicated volunteers. Dr. Zwolak was one of those original volunteers. That then evolved into the Health Policy Committee, which took on really anything government related. But then in 2016, when Peter Lawrence was president of the SVS, he elevated the Health Policy Committee to the level of a council. And this is our current structure. So the Policy and Advocacy Council oversees the Coding Committee, the Government Relations Committee, the Pac Steering Committee, and the VA Vascular Surgeons Committee. We have representatives from all tonight except for the VA Vascular Surgeons Committee for this talk. The council is comprised of a council chair, the chairs of each committee, and there's representative chairs from the clinical practice and the quality councils as well due to significant overlap. The role is to represent the interests of the SVS members and their practices in federal policymaking activities, to coordinate global efforts between the committees and report directly to SVS leadership, and to keep SVS members informed of legislative and regulatory activities with email updates and articles on important issues. So the Coding and Reimbursement Committee oversees SVS's activities at CPT-RUC and with coverage activities. Their charge is to participate in the RUC and the CPT editorial panel meetings representing the interests of vascular surgeons, comment on administrative actions such as NCCI edits and national and local coverage decisions, provide content and faculty for SVS educational efforts on coding and reimbursement. We review comments on regulatory issues before they're submitted to CMS, and annually reviews the coding section of the Vascular Web and advise staff and members on content. Government relations monitors and advocates for legislative and regulatory issues. They collaborate with organizations representing similar surgical healthcare issues, such as the new Surgical Care Coalition. We'll hear more about that later. They work through grassroots initiatives to including the calls to action and targeted campaigns. And they also work with grass tops outreach to help affect the policies we want to move forward. The Pac Steering Committee works for vascular surgeons and only vascular surgeons to ensure that the SVS members get access to U.S. representatives and senators in order to discuss issues that have a major impact on members and their practices. And the PAC supports United States congressional campaigns. The VA Vascular Surgeons Committee addresses the unique issues facing part-time and full-time vascular surgeons working for the Veterans Administration. They optimize the care for our country's veterans, create resources for VA vascular practice management. They do student, resident, and fellow outreach and mentoring. They have quality improvement projects, and they promote the careers of VA surgeons in all stages of their career. So we have multiple issues in play for this upcoming year, including the continued phase-in of updated pricing for supplies and equipment, We are undergoing a significant rewriting of the coding structure for lower extremity endovascular revascularization. There is a model policy that is almost ready for prime time that would be a model for any carrier looking for how to cover vascular lab procedures. But by far and away, the biggest issue that is looming over us for the upcoming year is the E&M coding changes. These changes will have significant implications for all SVS members, and they're scheduled to take effect on January 1st, 2021. So with that, I'm going to turn the speaker over to Dr. Zwolak, who's going to tell us how these codes came about.
Thanks very much, Matthew, and welcome all. I'm going to share my screen. I want to go up to here. Come on, screen. Very good. So the evolution of the E&M changes now given from the perspective of the joint CPT-RUC work group, and I'll explain what that is in a minute, but I was honored to be a member of that. So I want to first talk about the age of the current E&M guidelines that we use every day. So this handsome young guy standing to my right is my grandson at his graduation. The E&M guidelines were written before Christopher was even a dream in anyone's eyes. Likewise, mechanics and computer power have changed. So this is what a Palm Pilot looked like in 1995. I use this one frequently. Then we jumped forward in only 2 years to the real Palm Pilot in 1997, and some of you may still have this in some back drawer. But the point of these 3 slides is that the E&M definitions are amazingly old. They have stood the test of time to a degree, but in the digital world, they really don't. The existing 1995 and 1997 codes require entry of an enormous amount of clinically useless and burdensome detail. The chart you see to your left is an auditor's chart, just one of about 5 pages that an auditor might use to look at your notes to determine whether you qualify for a level 2, a level 3, or a level 4. And as you see, there are 8 different options for the history of present illness. And if you only get 1 to 3 of those, it's a brief. And if you get 4 or more, it's an extended. It's very important in the current system to conduct a review of systems, although I'm not sure any of us can imagine how many lives have been saved if your review of systems included 10 systems rather than 9. And this is what we lived with. And the reality is this is there for the purpose of conducting audits to make sure you have not overcoded. And the reality is, I think for most of the surgeons I know, that we just don't have time to put up with counting all these things. And so we're not very good at E&M coding. Everyone knew that the E&M codes needed updating. The AMA CPT panel tried several times, especially during 2012 and 2016, to update the E&M CPT codes, but they were so controversial that multiple efforts failed. And therefore, we've still lived with these 30-year-old codes and their coding guidelines. But then, starting about 2.5 years ago, CMS, pushed by Congress, proposed to reduce the physician's burden. And they proposed, in fact, an extreme solution. They proposed that there would only be 1 level of office visit, and there'd be 1 payment for office visit. And the clinical world reacted very negatively. There were thousands of comments that CMS received that, in fact, there are different gradations of office visits, and they should not reduce this to a single office visit. But that proposal actually spurred things on. CMS also proposed modifiers to enhance certain specialties. And this has escaped me how exactly they define this. I think it was primarily for budget neutrality, but with their system, certain specialties, not vascular surgery, but certain specialties had the option of using a modifier to increase the payments that they would get. And then CMS to the shock and awe of the whole world, said that they would do this with G codes. So they were proposing that they would leave the world of CPT, E&M for these most commonly reported codes and move to G codes, G standing for government, something that CMS can create at their whim. So this action really threatened the AMA CPT panel in the entire coding structure. As you all probably know, AMA makes millions of dollars from their CPT coding structure each year. And so the concept that Medicare would propose a G code alternative truly lit a fire under the folks at AMA. And they decided that it was time to get serious, and they created the CPT work group for E&M codes. And the work was extensive. I was honored to be put on this. I was actually a late addition. This is an ad for the September 2018 meeting. There was one before that, but it was noticed that there was not enough surgical representation and not enough RUC representation on this committee. And so I was not only the last one alphabetically, but also I think the last person invited to participate in this. You see that Linda Barney, who's a general surgeon and a member of the CPT editorial panel, is the only other surgeon in this group. We held many, many, many meetings. We had guidelines, and I'm going to take the time to read this actually, because this CPT work group on E&M was committed to changing the current coding and documentation requirements for E&M visits to simplify the work of the healthcare provider and improve the health of the patient. So we set forth the principles first to decrease administrative burden of documentation and coding. Second, to decrease the need for audits to simplify the whole system. Third, to decrease unnecessary documentation in the medical record that's not needed for patient care, the so-called note bloat that we're all familiar with. And lastly, to ensure that payment for E&M visits is resource-based and that there's no direct goal, at least in this effort, to redistribute payment between specialties. So with those guidelines, what did the CPT panel and the RUC do? So CPT went to work and redefined the new and established office visits. They used the same code numbers, but there are extensive changes in the definition of these codes. There's much less focus on inclusion of useless details. And in fact, the extent of history and physical exam, I'm sure you all remember counting bullets on your history and physical exam. The extent of the H&P is no longer an element in determination of the visit level. You should put in as much H&P as is necessary to provide high quality care for your patient. What they switched to is total time, and Sunita will talk to us more about that, as well as medical decision-making as a prime determinants of the code that you qualify for in these office visits. And there are new good things. In fact, things like interpretation by yourself of tests counts towards medical decision-making. So unlike many people who may just read the MRI or CT scan report, if we do our own independent interpretation, that counts towards medical decision-making. So the bottom line is the reporting burden absolutely goes down. What did the RUC and CMS do? So the RUC, despite the reduction in work, and I'll never forget this, I think was the only time in my life that I stood up in front of a crowd and disagreed that these RVUs should go up, but I did, but I lost. And the physician work of the office visits will go up as much as 46%. There's one that stays the same, the rest all go up. There's a very nice summary published by CMS in the final rule for 2019, and there will be a new rule come out soon if there are any changes. The bottom line is the reporting burden goes down and the payments will go up. This graph and the next one give an idea of how much the payments will go up. This one is the current and the proposed 2021 outpatient visit physician work RVUs. You see 99202 stays the same, but the others go up to various amounts. And this looks pretty benign. It's hard to think that anyone could argue too much with these modest increases. This graph shows the established outpatient visits, 212, 213, 214, 215 codes that we use all the time, every day. And now the most common code is 99214, the level 4 office visit. And you see it goes up 0.4 of an RVU. Well, that's not such a big deal, right? Well, think about it for a second, though. 0.4 of an RVU at $36 per RVU is about $14. Medicare pays for 100 million 99214s each year. So that's a cool $1.4 billion just for the increase in the work value of that one code. And don't forget, that's just the physician work value. There's also practice expense and malpractice that go along with that code, which will increase each of these even more than the estimate I just said. What else has CMS done? Well, CMS still intends that add-on gift code that I mentioned earlier. This was not something that was supported by the RUC. The RUC thinks that the values are coded correctly and no particular specialty or group needs a little gift code from CMS, but that is still in the CMS plan for 2021. CMS refuses to include the new values of the global surgery codes in the 10 and 90-day globals that we work with so commonly. The RUC did endorse inclusion of these new values in the global surgery package, and I think Megan and Sunita will have much more to say about that. The reason is that CMS believes that we actually don't perform the inpatient and office visits that are in the RUC database. I think that many of us would completely disagree with that, but there are publications by RAND and others suggesting that that's not the case. And so we'll have to see what goes along with that. But a lot of the dollar changes are impacted by these extra bullets that we'll hear more about in the next few presentations. The 2021 proposed rule from CMS should be out any day. And if there are any changes in their plans for 2021, we'll hear about it soon. So when the burden of these codes goes down and the RVUs go up, what could possibly be bad about that? Well, it's perfect. If all you do every day is perform office visits, it's a win-win if that's the case. Billions of dollars will shift to these office visits. And so if you live in the world of office visits, this is nothing but good. Unfortunately, Medicare runs on a relatively fixed funding pool, as we probably all know by this time. And everyone who does anything other than office visits will be donors. They will be paying for this change, which is shifting billions of dollars to these office visits. And just as a reminder, these are some of our favorite formulas. So y'all remember that the Medicare payment that you receive is the sum of the RVUs you generate multiplied by the conversion factor, and the conversion factor is dollars per RVU. So the payment comes out in dollars. The 2020 conversion factor is $36.09. Since the overall pot of Medicare, in particular Part B, is pretty well fixed, if the total reported RVUs go up, which they certainly will with these new codes, the conversion factor will undergo a compensatory reduction. So you go up on one side of the equation, but down on the other. You will earn less for each RVU you generate. And if you're an employed surgeon, you'll see a reset of your dollars per RVU in your contract. That is virtually a sure thing. And while we all perform a variable amount of Medicare work, the projected net loss to a vascular surgeon, your donation to increasing the value of these office visits, will be about $5,000 to $10,000 per year. So if you want to donate that, that's wonderful. If you want to work another 7,000 RVUs and earn back that extra money, you can certainly do that. But if you don't think you should be a donor for this option that we've just described, you need to listen very, very carefully to what Mike and Sunita are going to tell us, and Megan, over these next few sets of slides. So I think that's all from me. I appreciate your attendance very much, and thanks for listening.
Bob, that was an excellent review, and I appreciate you being part of this panel. Your knowledge on these topics is unparalleled. So now I'd like to turn it over to Dr. Sunita Srivastava, who's the chair of the coding committee. and she's going to talk about the creation and evaluation of these E&M coded changes from the perspective of the coding committee, and kind of pick up where the CPT RUC work group finished and how these codes moved forward and became what we're dealing with now. Sunita?
Hey, Matthew. Thank you, BZ, for that introduction. And as soon as this moves forward. Okay. I'm sorry, this just went up ahead a couple of slides. Thank you for your patience here. Just to briefly review sort of what our coding committee does. We are a group of very collaborative people. We work with other societies, the AMA, CMS, and you were essentially in two groups that work very closely together. The CPT aspect, where we create, revise, and delete procedural codes. We look for new codes and revise outdated procedures and exams. We look at flagged codes, and these are codes that are identified as high volume or billed together. On the RUC side, you know, we're advocates for physician work and practice expense. We also survey our members to establish work intensity and also review flagged codes, again, for the same reasons. We advocate on behalf of our membership by addressing third-party payer denials and try to rebut payer policies that are hostile to our practices. We serve in a policy and regulatory mechanism by reviewing comments from CMS and editing and looking at NCI edits. We also answer codes from coding questions and billing questions from the panels, other societies, and our own members. And we're always surveying the sort of evolution of vascular procedures and technologies to see what's coming up next and what we need to be prepared to value and to write codes for. And a lot of what we do is education and collaboration, as you can see here, and it's actually been a lot of fun. But speaking to our town hall, the E&M revisions from the coding aspect, essentially we're taking our old codes and we have essentially 3 new sets of codes. One addressing the new patient codes, established patients, and then prolonged services. And as Dr. Zwolak alluded to, we're looking at valuing them on different levels. And that includes medical decision-making and face-to-face time. So essentially the code set was simplified both for the new and established patients to remove unnecessary history and physical examination elements. And you can choose your own method of documentation based on face-to-face time or decision-making. There's a new code for prolonged services where you may add an additional 15 minutes to basically exceed the highest level code that you have built before. And this simplification eliminates some payment differentials between services. As Dr. Zwolak stated, these code sets are thought to be more efficient as they reduce documentation redundancy. You don't need to re-enter a lot of information, and the practitioner only needs to document what they've reviewed and verified. So the 2 primary components of your code selection are going to be your medical decision-making and the total time. When we look at medical decision-making, you can see that it's defined by 3 elements: the number and complexity of the problems that are addressed by the practitioner, the amount and or complexity of the data that's reviewed or analyzed, and this can include communications, information from multiple sources, interpretation of tests, and discussion with other physicians and qualified healthcare professionals. This also involves shared decision-making, both with the family, their preferences, and educating them. In terms of time, the total time on the date of encounter is the face-to-face time, and the non-face-to-face time that's personally spent by the physician or the healthcare provider. This can include the review of testing, obtaining a history, any medically appropriate examinations that were done, the counseling, education, and documentation of your interaction with the patient, and care coordination. So essentially these new E&M codes eliminate the requirements to provide medical necessity or documenting medical necessity. And it eliminates the prohibition of the same day E&M visits that are billed by physicians in the same group or medical specialty. And the documentation of a level 2 visit is sufficient for an office E&M. So if we look at the new patient codes, you can see that 99201, which is which was an old code, has now been deleted, and now we have 4 new codes that are either based on decision-making or time. So 99202, you can see, is based on straightforward decision-making, encompassing 15 to 29 minutes. And you can read the rest here. We are up to 99205, where you have the highest level decision-making and up to 60 to 74 minutes of practitioner time. In terms of the established code, we have a new series of code numbers ranging from 11 to 15. And 99211 does not require the presence of a physician or a qualified healthcare professional. This is a minimal problem that the patient is being seen for. For the 12 through 15, you can see as follows with these new patients, you have straightforward, low level, moderate, and highest decision making in addition to the times that are described here. Now the prolonged service code, which is 99XXS, is going to be effective in 2021. And this is basically a prolonged services code that captures the additional 15 minutes of critical physician or qualified healthcare professional work that's beyond the time that's captured with your standard outpatient E&M code. And this can only be used with the highest level E&M new patient and established codes, the 99205 or the 99215. And this prolonged code, again, is only used with those codes, and they're not reported with other prolonged service contact codes that we have in E&M visits. You would not report this code for any contact that was beyond your code less than 15 minutes. So this allows for both face-to-face and non-face-to-face care time at the date of the encounter. And again, I'm just including these 2 other codes that are used to describe prolonged services in the outpatient setting and non-face-to-face time in the outpatient setting, as you see here, the 99354 and the 99358. You would not be using the prolonged service codes in conjunction with these 2 described. Well, when CMS made this decision to update the E&M codes, they recognized that certain specialties often record or report a higher level of office visit, which would be the 4 and 5. And they felt that they proposed offsets with the addition of an approximately $14 for each office visit with a new G code, GCG0X. And this is to allow certain specialties that typically code a higher level of code to have an add-on code so that the work or complexity could be captured with the visit. They felt that the new payment system or these payment groups created both a significant negative and positive impact on specialties and may not address complexities adequately. So they proposed 2 add-on codes, one for the just E&M code and the second for the prolonged services add-on code. But this has created budget issues, and CMS addressed this by reducing payments for what they perceive to be overlap when the E&M is performed on the same day as a procedure, resulting in potentially a 50% reduction. So what we've seen here is that the E&M levels 2 to 5 were compressed to 1 single payment rate at a level 3. And it was felt that specialties that typically report level 4 and 5 would see payment cuts. So this add-on code, the GCG0X, was for additional payment. It has since been changed to 1 single code for these specialties that have been impacted adversely. But what we found is that CMS didn't employ the single payment system, so we still have the level 4 and 5 E&M payments. But the GPC1X code, so for the additional complexity, remains. And there's no explanation as to why these specialties still need an add-on code. There's no extra work, resources that have been identified. And this creates an imbalance for a need that no longer exists. And this further disadvantages all surgical specialties. So with the budget neutrality requirement, we have found that the GPC1X, which was initially proposed to address E&M financial impacts of certain specialties, now reduces payment for E&M codes for the date of surgery and as part of the 90-day global. And this redistribution of payment to certain specialties at the expense of others without data or rationale or resource input makes no sense. And this is what the crux of the issue is. It targets surgery unfairly. And if we look at the current law, which prohibits Medicare from making payments to physicians at different levels for the same work due to specialty, it's not in keeping with that. You know, surgeons don't bill as many E&M codes as other specialties, and this is going to result in a significant payment reduction for all of us. The reduction in the conversion factor from net neutrality will even worsen this in a situation where we're already experiencing a great deal of financial stress due to COVID-19. And these proposals can result in cuts to vascular surgery to as much as 7% of the overall Medicare revenue. If we look at this chart, you can see if we look at the current CMS policy and the projected 2021 Medicare payment, our specialty will be adversely impacted at minus 6.43%. If the add-on codes are eliminated, we will see, I mean, that will be reduced, but we'll still be, you know, having a negative impact. So I'm going to probably pass it on to Dr. Tracy to, I believe she's next, to further discuss sort of how we're addressing this in our specialty. Thank you for your time.
Thank you, Sunita. This is Matthew again. Before we move on to the financial impact and advocacy and the PAC about that, I've got just a question or two for yourself and for Dr. Zwolak about this great information you've given us. So Bob, I want to start with you first. So my impression in following along with this, as you and I have, this started with CMS making a proposal to compact all the codes into single codes for each visit, for each office visit. And their proposal was basically budget neutral. And we all said, no, all the House of Medicine revolted and sent negative comments, including us, that was a bad plan and we could do it better. And then it went from something that was burden reduction and budget neutral into what we have now, which is turning into a upwards of 7% cut for proceduralists and surgeons and dollars shifting to primary care. So I was curious about your insight on how it went from the original proposal to what it is now.
Well, there are many twists and turns along the road, but you're right. The original proposal that came out of CMS would have been budget neutral, and it would have primarily reduced the work burden without changing much the net dollars flowing to any specialty. That's what that modifier that Sunita just told us about was designed to do, was to keep the same number of dollars going to each specialty when using this new single code. When the proposal got to the RUC, even though under most circumstances, we who have attended the RUC for years and years say the burden is going down, the work to create these codes is going down, and so the work values really shouldn't go up. It was a gold rush, and some of the surgical societies objected, but there's a trigger at the RUC called compelling evidence, and compelling evidence says if you want to redefine something, there needs to be no change in budget, no increase in dollars. It needs to be budget neutral unless certain things have happened, unless there's been a change in technology, unless there's been a change in specialties performing the service. So you have to get through this hoop called compelling evidence. And in fact, once the presenting specialties, primarily the medicine and primary care specialties, managed to get through this challenge of compelling evidence, it was open field running. And so it's a sequence of events that has gone, as you say, from originally one code, budget neutral, to multiple levels of codes, which we probably think is fair, but the problem is that the multiple levels of codes have also resulted in this multi-billion-dollar shift to the codes. And so Would anyone have had the insight to predict this? I don't know, but once the system began, there was no stopping it.
Well, that's exactly what I wanted to hear you say. That's a great summary of it. And I can think of one person who did predict it and a couple of people who tried to head it off. But those are for stories after VAMs and over beers. Sunita, what do you see as the biggest challenges that you have on coding when we're trying to create new codes and value new codes? And if you have an audience of captured SVS members, what would you say about challenges that are faced with coding?
Well, I think that's a great question. You know, we advocate on behalf of the membership and we're happy to do so. You know, we all do that. I think that when our members get a request to fill out a survey, in particular for the RUC valuation, and we ask them to spend some time to really think about not their easiest case or their worst case, but to really take a look at, you know, their practice and give us some timelines and guidelines about intensity of work and medical decision making and, you know, time of the procedure. We want that information so that we can justify the value of the work that we do. So I think getting timely responses and accurate ones, you know, that does not a reflection of you personally as a surgeon, but you know, we really want to get paid for the work that we do, and we want these codes to reflect that intensity of work, that time, and what it takes for us to do it. So I would just, you know, ask our membership to, you know, answer the survey honestly and in a timely fashion, and you know, based upon, you know, an average case, and that would be great. That would be advocating on behalf of all of us. So thanks for that question.
Excellent, thank you. Dr. Hodgson, do we have some?
Anita, this may sound like a nitpicky question, but on most of your slides, you made the comment on day of encounter. It was a repeated statement, on the day of encounter, on the day of encounter. A lot of those services I provide a day or two later when I pull up films and look at them and review things, and I don't want to have to issue a separate bill for that. How critical is it that it be on the day of encounter?
Well, I think that, you know, if you look at medical decision making, there is for those codes, it includes the you know, the review of information that oftentimes doesn't happen on the day of encounter. That may happen, you know, after, and I think that's going to, or even occurs before as you review all this information. So it's really just to say the bulk of the work that you're doing on that day, but certainly it does encompass non-face-to-face time as you see, you know, as I described, if that answers your question.
And Bob Zwolak, you had mentioned that you can include in your billing, if you do your own readings of some of those tests, for example. How do you have to document that?
As I see it, you would probably include in your note or a template, if you have a template that said, I personally reviewed Mr. Jones' CT scan, and this is what I see. And I think many of us do that already. I doubt you'd ever fix an aortic aneurysm just by reading the report, or perform a distal bypass graft by reading the radiologist's report of some angiogram performed elsewhere. So I think that is a plus for us. I think it falls into the practice that we do every day.
All right, well, why don't you go on back to your next speaker, and then we'll have some poll questions and some chat questions after that.
Excellent. So our next speaker is Dr. Megan Tracy, Chair of the Government Relations Committee, who's going to talk to us about the financial impacts of these Medicare cuts and the role of SVS advocacy.
All right. So I appreciate the invitation. I think that Bob and Sunita provided an incredible overview of the process to establish the codes and to value our services and the mechanics of how those work, and really the impact on payments. So I'll touch a little bit on the financial impact of these Medicare cuts, as well as the role of advocacy and really moving the needle to keep this from happening. So So Dr. Zwolak's been making this point for years. There's been basically a 20+ year erosion of the valuation of surgical services since the days of the Palm Pilot, or at least a year after the Palm Pilot model that you showed. So, if you look at this conversion factor, back in 1998, if that had kept up with inflation, we'd be making $57 an RVU. We know we're making, unadjusted, exactly the same as we were making in 1998. So we're losing simply by standing still here. So these 2021 changes, just to briefly recap, resulted from additional payments for office services in addition to this add-on code. And the failure to include this additional valuation for evaluation of management services in the global surgical package. And again, this is where payment for your typical surgical case includes payment for 90 days, 10 days or 90 days, more commonly, worth of services following surgery, including all of the clinic visits, all the E&M type services that you provide that are really intended to be included in that valuation. So again, the projected impact of this on vascular surgery is about a 7% cut across the board for your Medicare services. If you look at the reason that this has brought the House of Surgery together, it's about $10,000 a surgeon, or $350 million in the first year, just impacting members of the American College of Surgeons, which is a substantial chunk of the House of Surgery, if not all. So what's the big ask here? The big ask here is really to pop the cork. It's to waive the budget neutrality requirement. That means that a big boost for evaluation management for the clinic services provided primarily by primary care, to make it such that doesn't necessarily need to negatively impact everyone else. So if you look at this chart, that goes from a 7% cut as a result of that 14% increase that Dr. Zwolak was inviting you to take out your checkbook and underwrite if you'd like to holding even for us and allowing that increase to go ahead so that it increases the size of the pie over this period of time. So how do we do this? I think the first step of it on the advocacy front is understanding the scope of the challenge. So actually just prior to COVID, a coalition of surgical groups underwrote surveys of the general public to really understand both where the public stands in terms of understanding these problems for us and being supportive or unsupportive of surgeons and our key decision makers. So what did we learn? We've got some good news. The public thinks we save lives. They like us. They think we're hardworking and meticulous. And on balance, they think that we work hard and, after all those long years of education, we overall earn our salaries, although we're not knocking that one out of the park. It's about a third of them strongly agree. And they like us overall. So a little less than nurses, a little less than their primary care physicians, a little less than emergency room doctors, but more than CMS or managed care organizations. So we're winning, I guess. There are some challenges in that survey as well. And this really speaks to why over time our policymakers don't necessarily feel the urgency we might wish them to feel in fixing this problem for us. Sure. Do we have a good bedside manner? Maybe. Are we meticulous and hardworking? Yeah, probably. Do we drive fancy cars? Yeah, absolutely. The public thinks we drive fancy cars, and most of them think that we earn our salaries. What's their take home from all of this overall impression of what surgeons are and what surgeons do and what our needs are, even after the impact of COVID? The majority of the public actually thinks that we made money on the COVID crisis from that increased volume. And the majority of the public does not think that we need any sort of bailout or help or financial assistance. They don't view the surgical community as being in distress. So moving on to surveying our own community and understanding what surgeons think of all of this, when we're turning to our own community as the folks who are going to have to articulate this both to the public and to our decision makers and policy makers, we have a problem. So if you look at this pie chart, very familiar. 4% of surgeons say they're very familiar with all the things that were essentially announced over a year and a half ago, that Bob and Sunita just explained, 4% of us said we could explain it in great detail. About a quarter have heard about it but don't really know the details. And close to 70% of surgeons say they've heard of it or just don't know anything about it at all. So we have a little bit of a hill to climb here as well. So what's happened on this front? Early in 2020, actually just pre-COVID, the SVS had been working with a broad coalition of surgical groups, but a core group called the Surgical Care Coalition, it's 12 surgical associations, was formed specifically to focus on this issue and to combine resources. The SVS made a substantial investment, as did the rest of these groups, to really become core members. So what does this involve? It involves data gathering, doing some of the modeling to see what the impact's going to be, doing these surveys, and really planning an advocacy and marketing campaign around this. So this is a splash page of the Surgical Care Coalition campaign. I'd encourage all of you to visit surgicalcare.org to see this. So what do? We're marshaling this data and trying to frame it in a manner that's really impactful to our policymakers and frames it in a way that it becomes urgent to them and urgent to our patients and not simply urgent to the pocketbooks of surgeons. So this is data that we should all know now from our own surveys. 35% of private practice surgeons are concerned about the viability of their practices, their ability to continue seeing patients. It looks at the impact or the response of surgeons to COVID, and really the number of surgeons who are really worried about the impact of this on their ability to care for folks. So what does this look like going forward? In the next week, most likely, Matt, wouldn't you say, we're expecting the final rule or the proposed rule for 2021, which is expected to include all of those same changes that were outlined here. Congress is going to get to work or continue to work on the next round of COVID-19 legislation. And we have this incredibly narrow window to really dig in and advocate incredibly strongly for inclusion of a fix to this in legislation going forward, or a fix to the rule. So this is really the July to September period. There's an opportunity to submit formal comments. The SVS always generates very, very detailed and well-received formal comments to the rules. That said, these will largely, I would expect, to be a recap of our comments to the 2020 proposed rule, which was not accepted in terms of changes in this regard. So there will be education of our surgeon members, education of legislators. There have been something like 50 virtual Hill visits or discussions with staff already by SVS staff and members on this front, and really the rolling out of grassroots and grasstops advocacy efforts by the SVS and by the Surgical Care Coalition. And we'll talk about this some. The final rule will come out in November, and if you think about what's happening between November and when these things come into play, January 1st, it's going to be an interesting time for the country. So every year, every time this happens, it's difficult because, you know, you fit in Thanksgiving, Christmas, New Year's, and various other things that happen. This year, we're fitting in an election and potentially significant changes in Congress, leaving us with a lame duck Congress, you know, and potentially changes in the administration. So here's a splash page of what's happened already, describing letters to Congress, describing surgeon stories of how they've been impacted and the essential nature of changes to these cuts to surgeons, as well as links to some really incredibly important placement of media stories in publications widely read by members of Congress and their staffs. And again, that's really been the work of the coalition and the supporting staff. So what's SVS doing in 2020? Working through the Surgical Coalition, sort of a broad group of surgical groups, through the Surgical Care Coalition, this core group focused on the single issue of these E&M payment changes, through efforts of folks like Dr. Zwolak working on the work groups and through the AMA. And the SVS will continue to advocate independently through the activities of the Policy Advocacy Council, leadership, and professional staff and consultants supporting that. So as a surgeon member, of the SVS. What can you do if you're concerned about this? Engage in grassroots advocacy. And we can talk about that. It's never been easier, and the SVS has never provided more resources to support your ability to do this. Step up as a grass tops leader. We'll talk a little bit about opportunities to do that. Volunteer on an SVS committee. I mean, I think that the excellent work that's been done for years with regard to establishing the value of these codes and the services that we provide has been provided free by vascular surgeons in their free time who've developed tremendous expertise. Dr. Sideman, having just stepped out of that role this year. And of course, support SVS advocacy through the PAC. And Dr. Delsing will talk a little bit more about those activities, but it's incredibly important. So grassroots activity, communicating with Congress and CMS through letters, emails, and participating in ongoing advocacy efforts. We have legislative calls to action. Now you will see email alerts and links. It takes less than 3 minutes to send very well written letters to your own members of Congress that you can customize or send them as is. Those are definitely impactful. There are going to be very targeted campaigns as this proceeds, focusing on truly key members of Congress, leaders of important congressional committees, members who are very receptive to support, potentially because they're in tough races, et cetera. And grass tops outreach, which is a new layer of this for the SVS in a formalized fashion, and that we've always had very sophisticated members of the SVS who've engaged in advocacy and are experienced, but we have a real opportunity to help build relationships of individual members of the SVS with key legislators. So what can you do? Let's talk grassroots. Answer the call. When you get an email invitation to respond through voter voice, asking for key provisions in future COVID legislation, click on that. So there's a direct link to the voter voice on the SVS site provided here, but you will also receive these in emails that will take you directly to this. Use these resources to share your story. Talk about how this would impact your practice and your ability to take care of patients. Talk about the impact of the events of this last year on your practice and some of the steps that you've taken to continue to provide safe care, safe PPE, take care of your staff, et cetera. You can locate and contact your legislators in essentially 2 clicks through this. Participate in social media activity to amplify this message. So we'll talk a little bit about that and the new SVS Ambassador Program. And look for opportunities to visit with elected officials. It's actually never been easier to visit with folks, either their staffs on the Hill, so to speak, or in district, as much of this is being conducted virtually at this point, and it's never been easier to use our support to do this. So the new social media champion and ambassador program really provides a social media kit to SVS member champions, people who are active on social media and would like to amplify the message. There is some interesting data with regard to members of Congress and how much attention they pay to various modes of communication. They pay some attention to letter campaigns, email campaigns, much more so if it's customized than if it's exclusively the form letter. They pay a ton of attention to phone calls. They pay a ton of attention to social media. They're all watching Twitter. Yes, they're all still on Facebook. They watch Instagram, all of these things. So language can be provided so that in addition to sharing messages or sharing links to SVS messaging and events, you can also share specific messages via each of these routes. So we'd strongly encourage that. We have incredibly active engagement already from members of the PAC and government relations committees who are recently surveyed and have signed on to be our initial crop of social media ambassadors. And you can look at the breakdown of how facile people are with these various modes of communication. And again, that's communication within the SVS, outside, and things that will be picked up by the members of Congress themselves. So look at this, and whether or not you sign up for the ambassadors program formally, you will start seeing these things coming from your colleagues. Use your ability to amplify that message. Incredibly important and heard by members of Congress. And I'd be remiss if I didn't mention ongoing policy priorities in 2020. As all the speakers here have noted, the front and center issue is really these Medicare cuts and the E&M changes. However, There's been a ton of activity this year on the coronavirus response, and the remaining parts of that include the loan terms of the Paycheck Protection Program and Disaster Loan Program terms, repayment terms of the accelerated and advance payments. All of these were really intended to address something that would be done in 8 weeks, 12 weeks. And obviously that's not what's happening. Watching disbursements from the Provider Relief Fund, liability protection for things including delays in care associated with following our guidelines with regard to operations of various urgency during COVID, as well as acting outside one's traditional scope of practice, the availability of PPE and supplies, and then ongoing incredibly important SVS priorities, including prior authorization, which it was recently pointed out on a virtual Hill visit just last night, is both a mental health and burnout and a financial issue for vascular surgeons. Red tape reduction and watching burdens on practice, including things like the EHR, and debt burden of our GME trainees, which is an even tougher burden in these difficult times. So thank you again for the opportunity to participate and for everything all of you are doing on behalf of all of the SVS members. And I would absolutely welcome questions from members, outreach from members to either the committee chairs or SVS staff from anybody who's interested in knowing how to engage effectively. This is the year to engage, and the next 3 months are the time to engage. So thank you again.
Thank you, Megan. That was an excellent overview of the excellent work that the Government Relations Committee is doing with this issue. And we've the coding has really done everything they could with these, and we've really passed the ball on to government relations. And we'll get to in a second to Dr. Dalsing with the third leg of the stool with the PAC. Dr. Hodgson, we have some poll questions or poll responses to go over. And
yes, if Blue Sky can go ahead and project the poll questions.
I think while we're switching over, Megan, I would ask, how has COVID impacted positively or negatively your work on the government relations to lobby and to connect with members of Congress about these issues?
I think it's been interesting. It's been a mixture of impacts. I do think that the surgical community was really brought to the attention of many members of Congress. They're very aware of the impact of this on the health and well-being of frontline providers. They're very aware of the financial impact on surgical practices and on their hospitals. Obviously, the hospitals tend to be bigger voices in their ears than we do, but they've heard that. So I think for the first time, it's actually been effectively framed. There is some understanding. Dr. Barrett voiced it on a call just last night that we're running businesses, that we're employing staff, that there's this entire network that we need to support in order to continue taking care of patients, and that it's genuinely under threat. And I don't know that in any of our discussions of the sustainable growth rate formula, of MACRA, of anything, that we've ever been in a position where lawmakers have seriously viewed our practices as under threat and our ability to continue to take care of patients as under threat. I mean, for all the 20-odd years of people threatening to drop out of Medicare, I think that's the first time that's happened. Like the PAC, we were on pause for a little while with regard to a lot of the traditional activities, because not only were all the surgeons' attentions turned to COVID, but the legislators were dealing with these COVID-related issues. So yes, there was a lot of advocacy with regard to things like the immediate shoring up of financial resources, personal protective equipment, et cetera, really the narrow COVID-related stuff. And just in the last, month, things have really picked up again, and we've all become, some of us more facile than others, with these virtual platforms, but incredibly active in terms of beginning to reach out. I know Dr. Dalsing has done a ton of visits across the Surgical Care Coalition. There has been a lot of communication. I know Jill Rathbun, who works for the SVS, as I mentioned, we've dropped the 50 number, and that's probably 2 weeks old. Has had probably 50 visits with our legislators getting this message out. So it is in full gear right now.
Great.
So here's the first poll question. There was a technical issue with this question. The first two options really weren't available initially, but I don't really think it would change very much. So this kind of reinforces what we've already heard from our presenters. The people were aware of this, but maybe not aware with the granularity that they need to be. Any comments about this from any of the panelists?
Well,
I think the overview that was provided today was absolutely spectacular. And I think that making that readily available through multiple channels and through the multiple avenues of SVS messaging is going to be really valuable to members going forward.
So along those lines, I will say that this town hall will be archived and will be available. There'll be links to it on the SVS website in a couple of days or so, so people will have access to that. While I'm thinking of it, I'll also say with regards to the Surgical Coalition that you may or may not know that the SVS has pledged $100,000 to the Surgical Coalition, the Surgical Care Coalition. So we've done our part to step up and contribute as well. So let's take a look at the second poll question. This was asking about would you participate in any kind of grassroots campaigns, and this was the so I'm not sure what's going on with our poll questions because this is both yeses here. So it looks like it's about a 50-50 in that regard, guys, in terms of participating in those. Let's hope we have more accuracy with our next poll question. There you go. Donated to the SVS PAC. Well, this is the big one, right? This is the kicker. And I think we have 100% donation at the SVS Executive Committee level, maybe even at the Strategic Board. But it falls off dramatically after that. And we'll probably be hearing some statistics about that from Dr. Dulcing as well. And then just the last poll question so that make that visible. So your PAC donations, I think Mike's probably going to cover this more in his talk as well, so I'm not going to go into great detail, but it funds all of this and more. So at this point, maybe it would be appropriate, Matt, unless you had any other questions, if you want to go. We do have some audience Q&A. We can do that after Mike's talk if you want.
perfect. So then I'd like to introduce Dr. Mike Dulcing, who is the newly elected SVS Vice President and the chair of the Pac Steering Committee. He's going to talk about how SVS PAC dollars fuel the fight against the E&M impact.
Thank you, Matthew. I'm trying to share my proper slide here. Can you see it all right?
Looks good.
Looks good.
All right. Well, good evening, everyone. And we're so glad that you took time to join us tonight. We know it's late, and we certainly appreciate you being here with us. As PAC chair, I have the privilege to present how your SVS PAC dollars fuel the fight against EM changes and the impact of vascular surgery. I included here the committee members for last year and for the upcoming year who have worked and will work hard to represent your interests to everyone in politics. So Webster's Dictionary defines a political action committee as a group formed to raise and contribute money to the campaigns of congressional candidates likely to advance a group's interest. But it really allows us the opportunity to talk to our representatives about issues we are deeply concerned about regarding practice and patient care. The interactions are often virtual this year, as Megan mentioned. One good example was a robust meeting between SVS leaders and campaign contributors from California. And I'll just mention a few. It's Dr. Dahlman, Weaver, Wu, Lee, and McGee, who were on with a number of us that night, with Dr. Amy Barra, who's representative from California. He is a physician as well. And I think we really got a good understanding of what there is in terms of understanding with our representatives, at least in some fields. So how do we determine which campaigns we support? Well, we keep an ongoing record of those who support our goals. The entire list with examples of support provided can be found on our website, vascular.org, under News and Advocacy, under Political Action Committee, and you hit Scorecard. You should know how your donations are utilized, and more importantly, why. Well, you'll see that many of the scorecard from select committees. Why is this? because these are the committees that impact our ability to obtain optimal patient care for our patients. These are the legislators that the SVS staff most closely work with during the congressional season. There are 4 main committees, 2 in the House, 2 in the Senate: the House Committee on Energy and Commerce, the House Ways and Means Committee, the Senate Committee on Finance, and the Senate Committee on Health, Education, Labor, and Pensions. Medicare, CMS, biomedical research, and a lot of other medical issues are handled through these committees. And that's where a lot of the administrators from SVS and on the legislative side actually get together and talk about things. But not all of these, not all the people that you see here are supported on these committees. We rely on SVS member knowledge and feedback gained through personal interactions with candidates, and we note their voting records. We gain information from like organizations on what issues a candidate is likely to support. Furthermore, how they support efforts to impact administrative responses, often reflected in the willingness to sign letters we author and then send to administrative agencies like CMS. I provide just 3 key examples here of what we might include in those things that legislators have supported that would reflect in our goals. One is being a co-sponsor of the HR 3107, which is to improve seniors' timely access to CARE Act of 2019. What this does is reduces prior authorization needs. So it improves your patient's access for you. Or co-sponsor of HR 1763, or on the Senate side, 348, Resident Physician Shortage Act. This would provide 15,000 additional Medicare supported slots for 5 years. In other words, providing training for your next partner. Or to congressional sign-ons, letters to CMS. The most important one in this act being letters to CMS opposing excluding global codes from the increased revised EMA code payments so that you actually receive the same fee for the same work. So if you're doing the same work, you ought to get paid the same. Now here's a list of some of those candidates the SVS PAC actually supports. I include this list not to demonstrate all the people that we support, but to demonstrate the bipartisan nature of our support. And in fact, you can see that a lot of the patients, a lot of the people that we interact with have some medical background, especially in the doctor caucus. Yes, when we provide SVS PAC funds to candidate, we do support their election or re-election bid, but more importantly, we have an opportunity to educate them regarding important medical issues, which otherwise they might not even understand. Understanding often leads to a change in action. We've seen that often. As you previously heard, waiving budget neutrality regarding the institution of the EM changes seems the most logical course to prevent undue stress on physicians, those ancillary care people that they have to support, and maintaining patient access. The PAC staff often acts on our behalf due to our very busy schedules. And I provide the multiple meetings that have taken place just in the last 2 weeks to address the EM relief, such as meetings with Senator Collins, with Representative Bera, Bouchon, Krishnamurthy, Taka, Shayla, and others. But really, they want to hear and they want to talk to you with their constituents and local leaders. Our PAC staff often tries to get involved, and I provide here 3 examples of where we were involved just recently. I had the opportunity in May 29th to meet with Dr. Representative Larry Bouchon. We talked about EM issues and a number of other issues. I was alerted to this. It cost us nothing, and it was great FaceTime. Dr. Krishna met with Representative Krishnamurthy June 26th, talked about EM changes and a number of other issues. His wife is a physician, so I think he understood a little bit of what was going on. A PAC contribution allowed that meeting. And then many of us, which I mentioned before, as well as people from California, met with Dr. Amit Berry, who also, his wife is also a physician, and he was a co-sponsor of HR 3107, which was the the bill to try to decrease the unnecessary work that you have to do to get patients taken care of. That was a very interesting and excellent meeting, I thought. Now, you want to use your time wisely, and involving grassroots efforts are much more important than you might think. If your representative doesn't hear from you, they don't think an issue is important at all. It just isn't on their radar. And furthermore, the squeaky wheel gets the most attention. So when you get these messages, just push the button. Basically, a letter is already written for you. You just have to personalize it. It tells you you're 2 senators and 1 representative. It takes 3 minutes, and it makes a big difference. So just do it. Now, the SVS PAC always fights for you, and we will. We appreciate your generosity, and thank you so much for past support. And we understand it's a time of uncertainty. There's stress emotionally and financially. We live it every day with you. Fortunately, life goes on. Unfortunately, if we are not vigilant, what happens in the government can negatively impact your patient's well-being and your ability to provide optimal patient care. So the SVS PAC still needs your help to be able to work for you. Participation is critical. The more people that stand up, give to the PAC, understand what it's about, will help us increase our ability to have an effect for you. Certainly, the more there are, the more they give, the more that we can do. A time commitment might be an option that you'd consider. So when you're invited, at least think about doing that. Finally, from the SVS PAC and the SVS leadership, I want to thank you for all you do. We certainly appreciate everyone's work, and we hope that people really start to understand what the PAC does for them. Thanks.
Mike, thank you very much. That was excellent review of the PAC, and the work that you do to get us access and to have our voice heard is crucial. If I can share my screen again here, I've got just 2 wrap-up slides, and then I think we can spend the rest of the time with Q&A. So the final points I want to make is that the E&M changes, E&M coding changes are approved and they're coming. They're going to result in a significant increase in expenditures just for office visits. CMS operates under budget neutrality, and that mandates that there needs to be an offset. What we don't know is how. There's several different things that could be out there to address this offset. Theoretically, the rule should have been out at right around the 4th of July, and we would have had some of these answers before now, but the rule is probably not coming out till Monday. One option CMS can do is to readjust all the RVUs. So as the office codes go up, everything else goes down a fraction to keep the net budget neutral. That results in everybody making fewer RVUs for the procedures they do and less for what they do in turn. The other option could be a decrease in the conversion factor, currently at $36.05. That could be offset to account for the billions of dollars that are going to be increasingly spent in E&M codes, reducing the conversion factor by 5–10%. So that you get paid less, you get the same RVUs, but get paid less for those. And then there's also a possibility of sequestration of the E&M codes, which would be the worst case scenario, where the values for the new E&M codes are held separate. The cost is then redistributed in what's left, and then the E&M codes are put back in. Hopefully we won't see that happen. The rule will be out any day now, and it will answer the questions of how and what shape these shifts will come in. The when we already know, January 1st. So how does this affect me if I'm an academic surgeon? How does it affect me if I'm a private practice surgeon, or if I'm hospital employed, or my practice is office based? Everybody is going to be affected the same way. It's either going to be lower RVUs for the same work, lower payment per RVU. There will be higher payment for E&Ms, but those higher payments weren't extended into the global period. So surgeons are going to get paid at a differential lower rate for the work that they already provide. But I hope everyone on takes home that message that no practice is safe and all practices will be affected by this. So with that, I'll stop and we can go to Q&A.
All right, if we've got several text-to-screen questions, if Blue Sky could pull up that screen for us, and then you can just take them from top to bottom if you want, Matt.
All right.
As soon as they get them up for you. So Matt, the first one, I'll just read it to you, is from Kevin D. Martin, asking, it says, as I understand it, the add-on codes were not going to be allowed for vascular surgery. Can you clarify that?
So that's correct. The add-on code, the GP C1X code, is specific for certain specialties, most of which are primary care specialties, and vascular surgery is not included in that. I'm a big anti add-on code person because that wasn't part of the original proposal. It was kind of left over from CMS's original proposal. And this one code with the projections that CMS is using as far as value and claims, because CMS is assuming that this add-on code will be claimed 100% of the time by every eligible specialty. So basically every primary care physician 100% of the time can add on this extra 15-minute code and tack on an extra 0.33 or 0.5 RVUs for payment of every visit. So the impact from just that one add-on code is almost the same percent and same dollar impact as the entire E&M set themselves. So just getting CMS to drop this add-on code would cut the impact in half.
So it almost seems to me like CMS has changed all the rules here in how they're approaching this now. And that certainly raises the question in my mind, if the outcome is not considered fair, is this subject to litigation?
So I know some societies are actually have lawyers looking into previous rules. There's definitely a rule on the books that prevents CMS from differential payments for different types of physicians. And just at face value, it would seem that leaving the E&M value changes out of the global package would qualify for that. And so of all the options that have been discussed on the table at the Surgical Coalition, litigation is definitely one of them. We, of course, don't want to have that be the first option. We'd like to address this either through rulemaking or through Congress, but litigation is not off the table, and I think there's definitely a case for it.
Yeah, that's been analyzed, and part of the issue is that the timeline requires that there's been harm. So really the harm doesn't start accruing until after these kick in January 1st. So we have this opportunity to stave them off, and if not, it's already been analyzed and that argument outlined, and certainly there's the precedent of some successful lawsuits by hospitals against CMS with regard to Medicaid payments and some other things over the last year or two.
So Matt, let me ask you before you go on to any other text-to-screen questions. You're chair of the Advocacy Council. The new rule is due to come out soon. Where should SVS members go for updated information when the new rule comes out? Or for, I mean, all I can imagine is that your request will still be the same, support the PAC and support our advocacy efforts, but how are we going to keep the members aware of what's been going on?
That's a great question. We actually have a pre-drafted email blast ready to go out through to all of our members once the rule is released. Obviously, with some of the key details left to be filled in, but as soon as it's released and analyzed, we'll send out an email blast to all members for our initial communication, and we plan to post up a lot of the detail from the rule on our advocacy section of the Vascular web. And we will plan on having other ways of education and communication for our members leading up to November and January.
Okay, you want to decipher this next text question?
So I was looking at via advanced accelerated payments, CMS provided looks like $1,001 billion to keep healthcare. With this in mind, how serious is the threat when we see CMS giving us a giant loan? And two, isn't trying to get Congress to forgive the AAP dollars a far bigger and beneficial goal? Thank you. Okay. So I think this is asking about the payments that Congress has already issued to people with the COVID crisis. Some of which were just advance payments and others were loans that are going to come due pretty quick. And the question is, wouldn't that be more beneficial? I think they're really kind of parallel issues. And the immediate advance and accelerated payments that are going to come due is a big payback for a lot of physicians. But just think how much harder it's going to be to pay those back if they don't get forgiven, if you're going to have to work 7 to 10% harder to make the same amount of income that you did before COVID. So it's not issues that we're ignoring. These are issues that we're working on simultaneously. But I think the E&M changes are going to have more far-reaching and longer-lasting effects than the accelerated payments. Anyone else have any comments or thoughts about that?
I think there are a lot of moving parts with regard to the accelerated and advanced payments, which really are, it's an established program and have been used in other situations as well. The program that was used by a lot of our own members, where you could apply for advances based on your historic billing with the understanding that you would start paying them back during a recoupment period. And I think that part of this is just how realistic is the ask, and is it more realistic to ask for reduced interest rates, for instance, on amounts that are not recouped during that period of time that actually become essentially an outstanding loan, to extend the recoupment period, et cetera, because CMS is really looking at this as a gigantic outstanding bill. So yes, that was on the list of ongoing, somewhat COVID-related advocacy items, and is important and certainly will be advocated on. But I think it comes down to an ongoing negotiation with the administration to see what's realistic in terms of terms changes for those payment programs. As anyone who was involved in the loan program saw, those were a moving target, in the terms of those evolved even during the first days of the existence of those programs. But looking at the repayment is an ongoing thing that we are keeping an eye on, will continue to keep an eye on.
Yeah, Matthew, it does make sense, right? But these are kind of individual loans to individual people. So it makes it harder to form an argument, as a society, to tell you the truth. But so I do see the logic behind it. I'm just not so sure how you would formulate the discussion when you talk to people. I think a lot of people are going to be asking for this, right?
It has been part of our letters to members of Congress and to the administration around COVID.
Correct.
Okay, it looks like the next question, we are only 4,000 people in our specialty, and medicine is much larger in number. If it is a numbers game, we would be outnumbered. Would we need to think different strategy to make our point? I would like to know if we have any ideas.
Matt, I'd like to start with that at least. I think the surgical coalition is the new idea because that gives us a lot more numbers. And the other thing that the survey that went out with the coalition did for us is it gave us talking points when we go to talk to the politicians. Before we really had any kind of information, especially the SVS information, that we didn't know exactly what was going on. We didn't know what the impressions were. And I think that information is really great. But I think the Surgical Coalition may be the bigger group that he's talking about. Megan, you may have a thought, or Bob.
I think that the budget neutrality issue takes it out of being a shoving contest between the specialties and primary care, and that's helpful. And I think the combination of that and the Surgical Care Coalition makes that both an ideal coalition, ideal vehicle, and kind of an ideal pressure point, because we're not just the medical community infighting, as we have in the past when we've been sort of divided and conquered on these fronts.
The other point is that these changes impact radiology and pathology. There are many other large groups of physicians who are negatively impacted by these E&M changes, and we're collaborating with them as well.
Great.
That doesn't mean that we should not advocate for ourselves, however. We have to be doing that as well.
Right.
But as the point's been made, we are the small guy here. So it's great to really see these coalitions develop. And as we said, the SVS is supporting this one as well. So any other new alternative strategies? Doesn't seem like we've been getting anywhere with our old strategies.
Megan, you want to talk about the marketing strategy and the political targeted strategy that the Surgical Care Coalition is working with?
You're muted, Megan.
You warned us. I think the biggest difference has really been the quality of the messaging. And yes, it's actually taken survey data that we paid to generate, that we generated. And as you saw in those examples of handouts targeted to physicians, handouts targeted to members of Congress and staff, packages that into really framing it as an impact on both what we do as a business and an impact on our ability to care for patients. The level of sophistication is substantial. I think that the ability to really have a coordinated campaign of targeting key members of Congress and a concerted effort. And I also think that one of the critical things has been this Surgical Care Coalition, and really on the whole, the medical community staying on point and not giving conflicting information or conflicting messages. There's really been this consistency of message to the point where, you know, on the call last night, we were talking about the timing of there actually being legislative language potentially introduced to support this, and what the next step would be to help build congressional support in the form of co-sponsors, people signing on to this legislation to publicly show their support, how we marshal our members to pressure their members of Congress, their delegations, to sign on and show their support, and then really help generate the momentum to move this forward. So I think at each of those steps, there's been better coordination, a significant investment by the SVS, and a better marshaling of resources.
Another point that needs to be made is that we shouldn't feel helpless because we're small. Remember, it was only 2 years ago that we, the SVS, engineered prevention of $100 million a year pay cut for vascular lab studies. That was all us. And so we've got some punch, even though we're relatively small.
I couldn't agree more. I would say that we have an excellent reputation with the AMA and on Capitol Hill, and it's due to excellent ground laying work done by the people who started this effort with health policy and now advocacy years ago.
I'd say just in a call for people to, our members, anyone who's on the call, anyone who watches this later, to engage both in the grassroots and to give to the PAC. You've really been incredibly well served over the last 20 years by individual volunteer members of the SVS, Drs. Wallach, Dr. Roddy, Dr. Sideman, and others, Dr. Dalsing, who have advocated incredibly knowledgeably, incredibly effectively on your behalf, and been all over the coding issues. Dr. Svs Town, another person who's been involved on the coding and RUC front for over a decade. This is a time when really those people are continuing those efforts, but are calling on you for your support, both in terms of financial donations to the PAC to really gain that access and push it forward, and in using the resources that the SVS is providing to engage on the grassroots front. So those people continue to do absolutely all they can, very knowledgeably and very effectively on your behalf. But if those 4,000 people are going to punch above their weight, it needs to not be 6 people or 5% of folks giving to the PAC. This is time for the entire membership of the SVS to step up and literally take 3 minutes, 5 minutes, pull out a credit card to support this effort that really, if we lose this one, is going to impact you for years. This is not going to be undone overnight. It's not going to be undone in a year. So it's this is crunch time.
And to amplify that even more, Megan, you're right. 6% of SVS gives to the PAC. That if we're 4,000 strong, that's not 4,000 people. 6% is not 4,000 people. We're talking a couple hundred. So if you really are interested in this, you kind of have to put your money where your mouth is. And so this is the time.
Yeah, and that's a quality and a quantity thing in that, yes, the dollar amount that the PAC has to spend is important, but the level of engagement is important too. When the legislators look at it and they say, you're like the realtors and 78% of your members give, everybody is paying attention to this, that means something. It's less compelling to go and say, 6% of your membership is incredibly concerned about this. So, even if you're giving a smaller amount, we understand that everybody is feeling anxious this year. It's incredibly meaningful, both as a gesture and a message, as well as a financial contribution.
So let me ask Mike Dalsing, maybe you were talking about the form letters and how easy it is to do. I've often been a little bit skeptical about how seriously a form letter, even a customized form letter, is taken by anybody, especially if it doesn't have a check in it. Maybe you could comment on that.
Yeah, it is all about the amount and the frequency. If their admin people see thousands of letters coming through email, and especially if they're personalized, if you add a little bit of something about your practice and how it's going to personally impact you, and maybe that you'll have to let a vascular lab tech go because you just can't afford it anymore. These and you're, especially if you're in their if you're part of their constituency, so is that person. So it starts to build up. So the more the better, the more letters the better. I think if you give somebody a call, it's probably a little bit better, but a number of letters sent by a lot of people, it's volume and quantity, and it is noticed.
Mm-hmm.
Okay, it looks like the last question is from Dr. Fran Aiello at UMass. Says, great talk. We speak about CMS reimbursement impact, which is obviously important, but seeing that most private carriers follow CMS guidelines, isn't the impact of vascular surgery even higher when we take all payers into consideration? And I think that's a great question, and it's obviously true. I'm sure everyone's practice is going to vary about what percentage of their patient population are Medicare patients. But the private carriers definitely follow CMS guidelines. They learned a long time ago it was a lot easier to let CMS invent the wheel, and if it saved them money, to follow along. And so this is definitely going to save them money. So I assume that they will probably follow suit. And so it won't just be your CMS reimbursements that'll be going down, it'll be all payers.
And is it fair to say that we really have no influence there? No way to deal with it at that level? This is the place we have to head it off.
We have some influence with some of the private carriers, but it's variable and it's not nearly as codified or strong as our ability to interact directly with CMS and change things at CMS if we don't like it through Congress.
And I think CMS does influence what the private carriers do, right? If they do it, it often goes to the private carriers, just the way it is. And it's hard to, and it's difficult to say anything against that, right? You're paying the older people a certain amount to get their surgery and more for somebody else. So it's just kind of what happens. It's not right, but it is what happens.
So we have a follow-up question. It says, two largest donors to political lobbyists are hospitals and insurance companies. What are the thoughts that politician would listen to us? Is it better to reach out to public at large and make our point over social media along with our PAC impact as our dollar value is small? Mike, you want to address that?
I can certainly try to address it. So we can't solicit funds from the public, right? Our PAC is an SVS PAC. So PAC members are the only one, or the SVS members are the only one who give to the PAC. If you're asking, should we use some of our money to get on social media and influence the public? I think that's a little more difficult. And the reason I think it's more difficult is that if you want to start these things on social media, you have to first gather that large audience, and then everything out there in social media can be influenced by someone else commenting on what you put out there. So it becomes a large group of people giving a message. So I think it's much harder to do that in social media. I think within ourselves, within medicine, that probably works very well. I think it would be more difficult to get to the public.
Megan, anything to add?
Yeah, and I think that part of the value of social media is really what we're attempting to capture with the ambassadors program and the social media work. But I think Mike is absolutely right, and I think you gained some insight into the extent to which there are some opportunities in terms of educating the public, but there are some pitfalls as well. I think that the survey of the public opinions about surgeons really tells you that there are some positives, but also some negatives about how the public views us. And there are some potential pitfalls in messaging. You know, I think that there are ways in which we're sympathetic to each other and other people in the medical community are sympathetic to us. And ultimately, a lot of the policymakers are sympathetic to us, where if you pick Joe off the street, who is also feeling stressed and at times may not feel that sympathetic, see also the fact that that survey elicited thoughts, feelings, and opinions about our cars. So you just have to be a little bit thoughtful about that. And it's a heavy lift. So I think in this very limited period of time, yes, there's some benefit to making sure that our image stays positive with the public and our message stays positive and patient-centered. But I think that we do need to focus both our effort and our finances on key pressure points where we're going to really move the needle.
Yeah, I would add there's with the current ongoing COVID crisis, there's been a lot of support and outpouring of support from the public to healthcare workers, especially people that are on the front line dealing with COVID. And that's something that we had talked about on some of these coalition things of how do we link our message of avoiding these cuts to the general positive feeling that the public has and the community has towards their doctors right now. And that's what the marketing people that we've hired are able to articulate and hopefully try to spin into a swell of public support for us as well at this critical time.
So Matt, there's an interesting question that's come through about what exactly should we be asking for. This is from Krishna Jain, and before you answer that, I thought I'd expand on that a little bit to say that when the SVS helps support people go do these activities, what kind of training and information do they give them?
Yeah, I can tell you the first time I went out, personally, I was quite intimidated going up to Capitol Hill and meeting with legislators. And the SVS government relations team and our advocacy team and the PAC team, we have excellent lobbyists that work on Washington, on the Hill in Washington, and they are really good at prepping members before you meet and interact with your legislators. They will give you plenty of information about what the talking points are and what the ask is for the critical issues at hand, and they will kind of coach you and help you about how to conduct those kind of meetings. The specific ask for the E&M issue is waiving budget neutrality. Just removing budget neutrality would drastically reduce the financial impact that we will all feel if these changes go through unabated, as they likely will come out in the proposed rule.
I would agree with Matthew. I think if you want to hit once and hit hard, that's exactly the right answer. If you have more of an opportunity or a stronger relationship with your congressional rep or your senator, you can add on elimination of this foolish add-on code that CMS is persisting with, and you can talk about inclusion of the new values in the 90-day global surgical packages. But those are a little more esoteric and a little bit more difficult than the single one-liner, hard-hitting, eliminate the need for budget neutrality.
Yeah, and I think if you start talking about too much, Bob, and you've seen it as well, you just get glassy-eyed. No one really knows what you're talking about. You have to have one message. I must admit, this is an interesting question from Dr. Jane, because he does some of this with us. So I think maybe his question was rhetorical. He wanted us to tell other people how this process works. So I think it was nice of him to ask the question. But yeah, you get one page, you essentially get one page list of what we should be talking about and what our position is. So it really, I think our government team really does a fantastic job. And I think if you ever want to do this, you can do it. It's not impossible at all. It's something you should be doing, especially if you know somebody, if you know a congressman or a senator. It makes a big difference.
If I could just add to that, Dr. Dalsing, I think that the SVS website for our younger members, or perhaps people who are not as familiar with these issues, feel free to log in and go to advocacy. And there's so much information and content that the SVS staff has put together for us, PDFs, summaries, about rules and legislation. You can even type in your zip code to find out who your local legislators are. So it's incredibly valuable, and you can get knowledgeable very quickly.
Well, I think we're getting towards the top of the hour, and I don't see any other text questions. Does anyone have any other points or issues that they'd like to make?
Well, I'd like to start out by once again congratulating all the SVS volunteers for all the work they do on policy and advocacy stuff. This is not the sexiest thing in vascular surgery, there's no doubt about it, but it is hugely important, and it gives us the income to do the sexy things that we like to do and everything. So you guys have just done tremendous work over the years in the SVS. We've got upcoming new people that are going to help continue to drive the membership forward and look out for the interests of vascular surgery, and I think we are fortunate to have such great volunteers on our members, or amongst our members, to do these kind of things. So in that regard, we're very fortunate.
Thank you very much. That's good. That's nice to hear.
So any other wrap-up comments from anybody?
Participate in grassroots, donate to the PAC.
Amen.
All right, very good. Let me just
fill out your survey.
Oh yeah, that's important too. So let me just briefly share my screen here to once again thank all of our panelists from today's town hall. We certainly appreciate not just your efforts tonight, but all of your volunteer efforts over the years and the years to come. And then lastly, put in a plug for the upcoming 3 summer town halls that we have scheduled, July 30th, August 13th, and August 27th, with more announcements to come moving forward. So with that then, I will stop my share and let all your panelists wave goodbye, and we'll sign off for the evening then. Thank you all very much.
Thanks. Good night.
Thanks. Good night.
Thank you. Good night.
Good night.
Thank you.